So we will be staying on the drug theme with Dr. Christopher Evans, Associate Professor of Medicine at Oregon Health Science University, who is going to talk to us about drug-drug interactions between the drugs you give and the drugs other people give on the street. So he's an infectious disease specialist in Portland, Oregon here. So he's a local person affiliated with OHSU Hospital, and internal medicine and geriatrics doctor as well, both certified in internal medicine and infectious diseases, and additional certification in HIV medicine. So welcome, Dr. Evans.
All right, good afternoon, everyone. Chris Evans here. Thank you, Dr. Badima, for that introduction. Thank you for the conference organizers for inviting me. Welcome to Portland. Welcome to sunny Portland. I'm sure you guys are enjoying the best that we have to offer. So yeah, today's talk, I think, just feeds right into what we heard a wonderful talk from Dr. Eden about opioids. And as you guys know, as HIV providers, I think we're really apt at thinking about drug-drug interactions. I mean, almost most things that we give have an interaction with something. And so when we talk about the interaction between antiretrovirals and illicit substances, I think this is kind of right up our alley. So here are my disclosures. So a couple of different learning objectives. At the end of this, I hope that you guys will sort of understand that when you talk about sort of drug-drug interactions, it's a really difficult question because there's so much variability. How I metabolize drugs is very different than how you metabolize drugs. Also, we know that when people buy things on the street, there's no standard, there's no FDA standard, so it's really hard to kind of say sort of what you're getting and how that's going to interact. Also know too that there are lots of risks that come with taking, what you buy on the street. So if you get something and you don't know what's in it, you may not necessarily be getting what you're asking, what you asked for. And so of course, that's going to lead to increased toxicities. And of course, I think the most important thing is to create the space to have those safe conversations with our patients. As you guys know, these are very traumatizing conversations for many of our patients, and so it's really good to create that space to have that. So I thought we'd just start off first with some facts about Oregon, not Oregon, Oregon. And so a couple of things I thought you guys would love to know about us. So first, if you get a chance, you can visit the world's smallest park. And so that's just down the street, and you can do a selfie and put yourself on Instagram. We are also the only state to have an official nut. It is the hazelnut. And so if you guys get a chance, you should sample some of our hazelnuts, and they're actually excellent. And last but not least, I think this is really important, we also have 1/4 of the country's llamas. And so I think if you're really sort of looking for the quirkiness of Oregon, I think you just found it here. What I feel more sort of pertinent to our discussion, really, why, I think we're apt to kind of why we're talking about this, is that we have been actually one of the very progressive states to legalize actually small amounts of drugs. So Measure 110 was approved a couple of years ago by the voters, and really what it did is that it decriminalized possession. So if you had a little bit of heroin, cocaine, or other illicit substances, you'd get a small fine, and of course, there was not a felony. So I think you guys have seen this iteration on many slides from previous speakers, but I think, as you know, we're just not heading the right way with substances. A lot of our folks are dying, and as you know, the opioid epidemic is all over. There are some states that have a higher issue than others, but at the end of the day, I think all of us are being affected by that. I know here in Oregon, one of the biggest things that we are struggling with right now is methamphetamines. As you know, of course, when our folks are getting meth, it's not just meth. It's meth mixed with fentanyl, mixed with a lot of other things. And so, of course, we are seeing overdoses. And of course, even for my patients who say that they're using meth, I'm also giving them Narcan. Cocaine is still around, not as much as other drugs. And of course, we're also seeing a lot of increase in the synthetic opioids, the fentanyl analogs, also the designer benzos, and of course, heroin is still an issue. So again, just while you're looking at this talk, as I said, it's very, very, it's a complex question. And I thought, and hope you guys bear with me a little, we're going to get to a little dive into a little bit of pharmacology, because I think it's the only way that we can really understand when we talk about drug-drug interactions, because there are just so many different variables when we talk about taking drugs. So as you guys already know, again, just from the pharmacology class, when we take something, when we ingest something, and we basically sort of absorb it, there are some really critical transporter systems that we use, our organic anion transporters, our ATP binding cassettes, and also things like our PGP that are really important transporters to kind of get things in and out of cells. Of course, things can also move from diffusion, from a area of higher concentration to lower concentration. Eventually, things will get sort of metabolized in a liver, of course, and we have things like our P450 superfamily, which is going to become very super important when we talk about it later on, and also glucuronidation with our UGP's enzymes. Of course, eventually we break everything down and things get excreted, either in our bile, fecal matter, and of course through our kidneys. The mode that we take things also has a strong bearing on how we metabolize it. Of course, if you snort something, you're going to have a very different bioavailability than if you sort of took it IV or IM. Age, of course, as we all get older gracefully, we actually, kidneys and our livers actually slow down also, so the metabolism of things could also be an issue. Sex, of course, is also a defining factor for how we metabolize drugs. Genetics. If I heard someone just talk recently about hepatitis C, if someone has underlying liver disease or kidney disease, we know a lot of our folks living with HIV are growing older, and so of course this does have bearing into some of the drugs that they'll metabolize. Genetics, of course, has a big issue in terms of some of the expression of the different cytochromes and, of course, the different transporters. And again, body composition, as we know, the volume of distribution of certain drugs will go down with things like pregnancy. So in the third trimester of pregnancy, the volume of distribution of drugs go down. And so, of course, all of those things come into play when we talk about drug-drug interactions. So again, as I said, this is complex. This is complex because there's just so many different variables. And this just kind of brings me to a story. So I won't name the coffee shop, but I went and I was on my 5th venti coffee, and I got cut off. And I was not like shaky, I was not nervous, but I really think that I actually am one of those folks who is a hypermetabolizer of caffeine. Caffeine does nothing to me. I could actually drink 5 cups and go to bed. And so again, we all have different sorts of expressions. And so when you think about sort of the genes that we use, so there are genes that we express that people are hypermetabolizers. Sometimes some of the genes are not working, and so of course, if the gene's non-existent, you will not metabolize that drug at all. And we know that especially with some of our things like efavirenz. We know that for people who have a change in certain alleles and they're slow metabolizers of efavirenz, it actually leads to more sort of neuropsychiatric symptoms. And so again, when we're talking about the interaction between our drugs that we're giving our patients and of course what they may be taking, if someone's not metabolizing their Sestiva or someone's not metabolizing a protease very well, that's going to have a very different interaction between different patients. And of course, that of course puts the person at risk for increased toxicities. So again, I said, sorry again about a little pharmacology, but I think this is really important to understand that, not only are there genetic differences in the cytochromes that we express, but there are also genetic differences in the transporter systems that we actually express also. And one of the key ones that will come up later on in our talk is PGP. It's an efflux transporter, and we know one of the things is that it is inhibited by ritonavir or cobicistat. So of course, if someone has a different expression of PGP or they're taking a boosted regimen, that can have a really drastic interaction with drugs that they may be taking that are substrates for PGP. Of course, again, they are things that are going to be absorbed at different rates. And again, some of the ARVs that we give, things like dolutegravir and so forth, can be potent inhibitors of some of these transporter systems. And so I think it's really important, again, to understand why this is a complex question to answer when we talk about drug-drug interactions. So again, I think someone said before, what you buy is not what you ask for, is not what you get. And so there are no FDA sort of specifications for the things that our patients are going to get on the street. And we know that a lot of times, many of the drugs that people are getting are adulterated. So I think I just heard about xylazine or tranq. This was a study that looked at different drugs that were seized, and there are regional differences in the types of adulterations that people are seeing in drugs. There are things that are being put into the drugs for bulking agents, but there are also things that are being put into drugs for actually added effect. So for example, with Levosolol, which is an antiparasitic agent, that actually causes more of a feeling of euphoria when it's added to things like cocaine. With things like fentanyl, and we're seeing a lot of fentanyl with tranq. With xylazine, xylazine actually gives fentanyl its legs, as people would say. It actually causes more of the effect of taking fentanyl. And of course, with things like heroin or so forth, there are added things. There have been things like Benadryl, quinine, of course. We know, of course, with the metabolism of some of these drugs, the impurities are still in there. And so when we're just talking about the drug, we're not just talking about the actual parent drug, but we're also talking about all the metabolites that are going to be coming with someone actually making that drug that are actually in the drug that someone's buying on the street. And of course, with MDMA, we're seeing things like our synthetic cathetone, and of course, our methamphetamines, cocaine, and ketamine are also things that are being seen adulterated in these drugs. And if you can see on this picture right here on the right-hand side that, if you look at the drugs that people are buying on the street, you can't really tell the difference, right? Like they look the same. And so again, when our patients think that they're getting benzos or when they're thinking they're getting some sort of pill on the street and it's sort of, adulterated to sort of look like something, then of course they have a big risk with some of the drug-drug interactions that might happen. So I won't go too much into sort of the xylazine since it was sort of mentioned here, but there are some things that are coming out. I call the new kids on the block. And so, of course, we have the tenazines, which are old drugs, but coming back again. But they are supposed to be about 1,000 times more powerful than morphine. And as you can see, people are calling these the Frankenstein opioids. They don't resemble fentanyl, but they are very potent agonists. Other things too is things like carfentanil, which as you guys may know is a large animal tranquilizer being used for things like elephants, should not be used in human beings. And of course, we're seeing it in regional differences being adulterated with drugs. Xylazine, as the speaker spoke about before, is something that we're seeing not too much here in Oregon, but again, we are seeing it in other states as it's being adulterated into other medications. And as patients have told me, it just sort of helps things like fentanyl just kind of have its legs. Xylazine is basically an alpha-2 agonist, and so adrenergic agonist, and so basically just like clonidine, it just helps people feel sleepy and calmer, and so just adds the overall effect if you took some xylazine with something like fentanyl. So we're going to take a little bit of a walk back in time just to kind of illustrate a point. So here we have a case of a person who, this is a walk back in time is 2007. This is a 40-year-old guy who is HIV positive, and he was diagnosed just a couple months ago. He is on methadone for opioid use disorder, and he's also on efavirenz, tenofovir, and emcitabine as a combination pill. As he was started on this, what his provider noticed is that he was having more cravings. And so because of that, he actually got his methadone dose increased. And a couple days later, while he was just waiting there at the bus stop, just kind of there, he collapsed. And this was the EKG that they found. Do you guys know what happened? Yeah. I heard the answers. Yeah, this is an additive effect. I mean, there's just so many things that happened here. So one of the things we know is that methadone is metabolized by the CYP3A system, right? And we also know that that system is inhibited by certain antifungals, things like fluconazole. Unfortunately, we know that efavirenz could also induce that system, and so it can lower methadone doses. There is some sort of literature supporting that if someone is on an efavirenz-based regimen, again, that's going to be few and far between now and the current guidelines, but that the methadone dose would probably have to be about 22% higher just based on the induction. We also know, too, that efavirenz, again, there are differences in the expression of the enzyme that will metabolize efavirenz. So the CYP2B6, again, is responsible for that. And if you have a deficiency in that, of course, the big issue is that you can have higher doses of efavirenz. So if you add all of those things together, high doses of methadone, high doses of efavirenz, and of course add fluconazole as the inhibitor, of course that increases your risk for QT prolongation, and then this was a tourist response. So as we look again, not to sort of reemphasize sort of what other speakers said, but I think we all know that opioid deaths are increasing around the country, and here in Oregon we're no different. And most deaths from opioids are due to overdoses and not suicide. And then we know, of course, the folks that we are seeing in clinic, just our folks living with HIV, have a lot of barriers that they have to overcome. We heard about the social determinants of health. There's a lot of disparities all over the country with access to different things. We also know, too, that a lot of our folks struggle with chronic pain, things like HIV, neuropathy, avascular necrosis, and osteonecrosis. And then, of course, we also know there's a high comorbid risk with things like mental health illness, and of course high substance use. Even though I think we've made such really good strides with increasing life expectancy for folks and people living longer and healthier, we're actually taking a step back. And if you look at the graph at the bottom, you can see that even though the life expectancy of the deaths of folks living with HIV fell by 13%, that opioid deaths have increased dramatically, and that has increased by 43% between 2011 and 2015, with the highest risk of an overdose being those who actually, their main risk for HIV was by IVDU. So we really are kind of taking a step forward, but we're also taking 2 steps back. So fentanyl, the blues, as my patients call them, really it's 50 times more powerful than heroin. It is very lipophilic, so it gets into the brain. And the thing about it is that when people buy fentanyl, they're not just getting fentanyl, they're also getting a lot of the fentanyl analogs. So there's valifentanyl, acetylfentanyl, and all of the different sort of fentanyl analogs have different potency depending on sort of the type of fentanyl. The issue for fentanyl is that it is metabolized by our CYP3A system, and so our inhibitors or strong inhibitors like ritonavir or cobicistat will increase fentanyl doses substantially. So we're talking about a really powerful drug, and then you add an inhibitor to that, it can increase by about 174%. And as you guys know, people are not just getting fentanyl, they're getting fentanyl plus other things. And that does, of course, put someone at increased risk for respiratory depression. And of course, if you discontinued it, it also could put someone in withdrawal as a theoretic risk. So opioids, I sort of took fentanyl sort of separate because I think it just has its own issues. But when we think about the other sort of opioids that people might be buying, we think about things like oxys or hydrocodone. It really does come down to a couple of things. I know this is a very busy slide, but I just want to kind of bear with me. So one thing we know is that when someone takes a drug like oxycodone or hydrocodone, drugs can be metabolized from the thing that actually causes the pain relief, the analgesia, to something that actually causes less pain relief, right? And so if you are sort of blocking sort of that metabolism, you actually might increase the thing that actually is causing people to actually get more pain relief. Of course, there could be more toxicities. But if you are blocking the enzyme that actually is responsible for metabolizing the parent drug to give you the thing that actually gives you more analgesia, then in theory, you could actually be blocking someone from actually getting the pain relief that they need. And so again, if you look at the two sorts of enzymes here, we have our CYP3A, and of course, that is inhibited by cobicistat and ritonavir, and that can increase oxycodone levels by about 2.6%, and hydrocodone levels also. And then if you look at our inducers, things like efavirenz that induce our CYP3A systems, we can find that that can actually increase noroxycodone. And noroxycodone and oxyhydrocodone actually are the metabolites of those two medications, but they actually don't provide pain relief. So if you give someone an inducer, they could actually be getting less pain relief. And then again, if you sort of give someone something that inhibits the CYP2D6, which is also an important enzyme in metabolism of opioids, you actually might get less of that hydromorphone, or sorry, oxyhydrocodone, less hydromorphone and less oxyhydromorphone, which is actually one of the metabolites that's really important for analgesia. When we look at sort of things like heroin, heroin is metabolized in a slightly different pathway than the CYPs. That usually goes through the glucuronidation. And the thing that's really important about heroin is that it really gets metabolized into morphine, and really that's kind of like what a lot of our opioids want. It gets inside the brain and it really wants to be morphine. And there are efflux sort of mechanisms to kind of pump that out. And one of the most important ones, as we said, was the PGP. And so when we take drugs like ritonavir or cobicistat that actually inhibit PGP, we actually can increase the levels of some of those opioids as they sort of cross the blood-brain barrier system, and of course, increases risks for toxicity and sedation. We also know, too, again, that a lot of the drugs like CYP2D6 and, of course, even 3,4-A have polymorphisms, and so everyone will metabolize these at different rates. So I'm going to kind of pivot a little bit to something that is still, I think, around, and of course, folks are still struggling, and that's about chemsex. And so here is a quick case. We have a guy, 45 years old, who's living with HIV. He was diagnosed in 2011. His ARV regimen, he's on darunavir boosted with ritonavir, and he's on tenofovir difumarate and stridobine. He has a past medical history of depression. He has a seronegative partner. He works as a freelance designer, and he's doing well. He is taking his meds. He's undetectable. T-cell count is 440. But he does say something to you. He says, you know what? I do party and play on the weekends, and I want to know, like, should I hold my meds? There are a lot of patients who will tell you that they don't want to take their HIV meds because they're really afraid about it interacting with other things that they may take. And of course, if they do have interactions, what kind of interactions might those be? So again, just sort of diving into the world of chemsex, it is a lot of different things, a lot of different medications, crystal meth, MDMA, ketamine, mephedrone, GHB. Of course, poppers are still around. Depending on how people use those drugs, you can have different sorts of effects. And modes of use could be things like snorting, smoking, interrectal administration. And then there's also slam sex, where people actually will use it by injection. We know, unfortunately, this has been seen a lot with our MSMs, and a lot of our MSMs living with HIV. And of course, there's a lot of people in literature supporting that chemsex, especially in our seronegative folks, is an increased risk for getting HIV. And so this was a study that looked at folks who were HIV positive and folks that were HIV negative. And I think what is very evident is that the folks that were HIV positive had a higher prevalence of use of chemsex drugs. But again, as I said, it's a really complicated question when we talk about drug-drug interactions. So this was a study actually out of Spain that looked at drug-drug interactions with folks who were living with HIV, and they used Liverpool, and they looked to see sort of the drugs they were taking and sort of the clinical outcomes. Like, did they fare poorly because they were using drugs associated with chemsex? As you can see, a lot of the folks were on boosted ART regimens, about 30%. And the kinds of drugs that they were using were things like methamphetamines, GHB, of course, poppers, and of course, many people were using more than one drug. And when they sort of looked at this, they found there were about 2,048 drug-drug interactions, and they sort of graded them as green with no interactions, yellow as more moderate, and then orange as more severe. And they found that actually people, even though they had more orange, they didn't actually fare worse. They didn't have more hospitalizations. They didn't end up in the ER more. They might have had more medical visits with their providers, but at the end of the day, as compared to others, without those drug-drug interactions, they didn't fare any worse. And so again, I think it's a very mixed picture about whether or not, say, especially with party and play drugs, whether or not people always have poor outcomes with chemsex. So when we look at our stimulants, I think as you guys already have heard, the things that we see here are crystal meth, so methamphetamines. There are different mechanisms for sort of how meth works versus cocaine. Cocaine kind of re-inhibits sort of the transporter system and uptake of dopamine, while methamphetamine does the same, but it also sort of helps kind of pump out dopamine into the synaptic cleft. And so people at the end of the day get like a really euphoric sort of feeling if they're using either cocaine or methamphetamines. With methamphetamines, again, people can smoke it, they can use it intrarectally, they can use it IV. It does peak very early after using, and it is highly associated with non-use of antiretrovirals. Depending on how you use it, depending on how you use it, you can also get a different kind of bioavailability. So of course, using it IV, you get more of the effect. And the physiologic effect, of course, are things like arrhythmias, of course, and hypertension. There is an interaction because it is metabolized by the CYP2D6 system, and so strong inhibitors of that system will actually cause methamphetamine levels to increase substantially. Cocaine is metabolized, again, mostly by a non-CYP system. Only 10% of cocaine is metabolized by CYP, and it's usually CYP3A. For drugs that induce the CYP3A system, the big issue is that cocaine then gets metabolized into norcocaine, which is considered to be hepatotoxic. And so at the end of the day, that's something to be aware of. Another thing, too, to be aware with cocaine and drug-drug interactions is that the drugs that we give, the antiretrovirals that are QT prolonging, things like fostemsavir or even rilpivirine, those medications added to cocaine may increase the overall risk for QTc prolongation. And of course, as we saw with the Torsades, that can be a big risk after all. Ketamine, Kit Kat, Special K, of course, it blocks glutamine, and of course, because of that, it causes more dissociation, people get respiratory depression, hallucinations. It is sort of metabolized into norketamine, and that's done through the CYP3A system. And so again, similar to past drugs, big inhibitions with our CYP-A system with cobicistat, ritonavir, or induction, of course, can actually cause more of the metabolite and then cause more toxicity. GHB, GBL. GBL is a prodrug of GHB, of course, and it's metabolized very quickly. People get respiratory depression, party and play drugs. It's used a lot with ketamine. And the good thing about, at least for drug-drug interactions with GHB, is that it really isn't really metabolized by the CYP system. It's metabolized more in sort of mitochondria and expelled as CO2. So there's really not a lot of interactions with GHB. And I had to put up Mr. Von Meow Meow. So this is my cousin's cat. And so Mephedrone, known as MCAT, meow meow bubbles. It's snorted, injected. It's sold as bath salts. It can cause a lot of surge in happiness. People feel great. It stimulates the release and reuptake of dopamine, serotonin, and norepinephrine. It also is metabolized by the CYP2D6 system. And again, there are genetic polymorphisms with this. About 3% of folks who are Caucasian actually are missing the CYP2D6 system. And so, again, this can really to increase risk for toxicities. And so, again, just to be aware of the drug-drug interactions. MDMA, that of course known as ecstasy, rapid release of serotonin. It is metabolized by the 2D6 system. Again, if things inhibit that, such as ritonavir or so forth, it can increase the risks, again, with even like a serotonin syndrome because of the drug-drug interaction that can happen. So I'm going to go forward because I know I have the last couple of minutes. So this is a guy who used poppers and he turned blue. So it's not a Smurf. Well, okay, what do you guys think it is? This is methemoglobinemia. So this is actually something that can be done, can be seen with folks that use poppers. And of course, it doesn't interact with any of our retrovirals, but it might interact with things like erectile dysfunction drugs, and I think it's something to kind of be aware of. So the last couple of slides, I'm going to move quickly, but just to kind of be aware, this was a study that looked at folks who were afraid of taking their medications when they were using drugs. And so I think it's one thing that we think we need to bring up with our patients because, again, if our folks, especially if they're holding their ARVs, of course, this can actually increase not only issues about toxicity, but of course, poor outcomes for their HIV. So we must have these discussions. They're challenging. We also have to address confidentiality. We should avoid using subjective words, non-judgmental, use closed, open-ended questions. We prefer closed-ended questions for specific stress-free responses, and of course to inquire about frequency and duration. And again, set up a safe environment. And we know it's a continuum of care in terms of, the things that we're going to do for harm reduction. So again, there's wide variability for the metabolism of these drugs. We know that some of the CYP systems will have variabilities based on just expression, or transporter systems or CYP systems based on genetic expression. It's essential that we have these conversations in a safe space with our patients to foster open communication. And again, at the end of the day, vigilance is always part of our clinical care. And I think going back to what Dr. Eden said before, is to really create these low barrier treatment systems and social support mechanisms for our patients living with HIV. Thank you.
So as I'm waiting for people to get to the microphone, just one quick question. Are you considering different antiretroviral regimens for initiation or to switch people who are substance users, or are you avoiding use of PIs, boosted PIs, for instance?
That's a very good question. I think at this point, because there's just so much variability, I think it's a hard thing to say that I wouldn't give someone a boosted regimen. I think if they need a boosted regimen because, say, they're someone who has a lot of mutations that need to be a boosted protease, I think I would still give it to them. But I think I'd also have that conversation with them and say, hey, you know what, you're on a medication that can, have a risk of increasing other things that you might be taking. And so what you're buying on the street, you might be getting that times 10. And so I think it's really just kind of a conversation to have with patients rather than changing their regimens.
Okay. I have a question here. Any drug-drug interactions with hormones, prescribed or not, for gender-affirming care?
Yeah, that's a really good question. So I know that for a lot of our folks with who are getting gender-affirming care, that has been a big issue for folks even wanting to get on antiretrovirals. And so I don't do a lot of gender-affirming care in my clinic. We have an amazing transgender health program. But in terms of thinking about the medications that I would prescribe, I mean, for most folks right now, we're probably starting someone on an integrase-based regimen. So there's really not a lot of concerns I would have for drug interactions with someone who needed to get gender-affirming care.
All right. Microphone in the Eastern Time Zone.
I had two things. The first was just a comment specifically for acyl nitrates, and also known as poppers. You didn't mention it, but there is also a pathology called popper maculopathy. I've had a couple of patients who have developed permanent macular issues due to popper use, and being one of the most common chemsex drugs. It's important to recognize that.
Thanks for sharing. I wasn't aware of that. Thank you.
And then I was wondering if you know of any resources where these drugs of abuse can be added into a medication review, because it's very difficult for a lot of these, especially with the non-HIV drugs, where the Liverpool drug-drug interaction is available. There's not really one, as far as I know, for drugs of abuse.
Actually, so Liverpool actually, you can actually enter drugs of abuse. So you can enter cocaine or methamphetamines and into the Liverpool, and it will actually give you some outcomes. Again, a lot of the data, it's going to be really hard, I think, because the evidence that we have, we're not going to do a lot of clinical trials with these things, and so a lot of these are just maybe cases or antidotes. So the data is really poor about kind of what we're seeing, especially with some of these new drugs. I didn't mention the things like our designer benzos. That's a whole kit and caboodle. And so when we talk about sort of drug-drug interactions, I think there's just a lot that we're just missing because we just don't know.
Thank you.
Mm-hmm.
Yes, please.
Hi, Adam Lake. I'm a huge drug nerd, so I love the talk. I would also just kind of add on to for the last speaker that that's assuming that the patient and we know what is in the drugs. I want to give a shout out to a resource, the Center for Forensic Research, Science and Education, CFRSE. I always mess up the acronym. But they release quarterly reports about what it's actually in the drug supply. They'll do actual testing of samples sent from different places around the country, so you can get a sense of what's actually there. And I've had some actually really good conversations with patients as just being able to have that conversation about like what are you actually taking and what are things like out there. And I think that's been really helpful having that as a resource. So I just want to give a shout out for that.
Thank you for sharing. Yeah, the more resources we have, the better, because again, it's just not a lot of literature out there to kind of give us guidelines about what to do and what to expect when our patients are using.
Yes, please.
One other shout out for drugsdata.org. It's very similar, but up to the minute, or up to the day or the day before, and you can look regionally, and there are pictures of the substances, and so looking with patients, the color of things, what people bought them as, and what they ultimately were tested as is another great resource.
Oh, perfect. Thank you for sharing.
I think a theme that is emerging here is that we will be helped by having a good compendium of resources to look at. You know, that's I guess that's also could be harm reduction.
No, you're right. I feel like, a lot of us are in the dark, again, what our patients are using, because, again, I can say that even our clinic, having those conversations are difficult. Number two, we don't know what patients are buying, because, again, there's no standardization. And then all the other things that have to happen to sort of metabolize that drug is just, it's complex. But, yeah, definitely.
There's this one drug here that this question is referring to. Is alcohol still the substance use associated the most with non-adherence of ART? Is that true?
So to get kind of on the pharm side, so alcohol induces the CYP2E1, which is one of the cytochromes, and it's not a major sort of metabolite for some of the antiretrovirals, but we also understand too that substance use, any kind of substance use, including alcohol, can sort of affect people's abilities to take their medications. We also understand, too, that alcohol does affect your liver, and your liver is a major organ that's responsible for sort of breaking down of drugs. And so, if you have a person who has heavy alcohol use and is a cirrhotic, that does bring into a lot of sort of complex drug-drug interactions that we have to be aware of.
Okay, I don't see anyone else in the microphone.
Well, thank you very much. Thank you for listening.